And I might have written it somewhere. I think when I sent out an email originally, I think I might have put that the topic of children was there, but then I revised it. Yeah, so yeah, on Moodle. So then I think I sent out another email saying, when I sent out the study guide, that it's just going to be the organ transplant, renal disease, chronic kidney failure / dialysis stuff, respiratory, and autoimmune. That's all that's going to be on the exam.
You might need to on Moodle, but that's
I think it's on the study guide that I sent out. I think those are the only highlighted topics. So that, yeah. Okay, so I have my little thing set here so I don't go over. So we'll talk about autoimmune conditions for the next minutes. And then these are the two chapters, depending on what edition you have. I think most of you have 5th edition. And then these are the, oops, not on the right. I'm almost there. And then here's the objective. So you guys can read through that. Just autoimmune diseases are kind of funny because there are so many of them. And so it ends up being kind of something that you have to just dial in with your patient, talking to them about their experience. But we want to overall try to understand immune dysfunction, describing some of the pathophysiology, talking about and discussing some of the medications that patients could be using, and then how it can implement our practice as dental hygienists, recognizing some of the oral manifestations, and see how it can affect the treatment plans, and if it's always safe to treat a patient, or if there's any time when we have to like postpone treatment or something. Those are the main objectives. And so when we kind of give an overview for the immune system, pretty amazing and complex system. And there's a lot more to know about it than what you guys really have to know. So we just kind of boil it down to these two terms. There's something called self-tolerance, which it's when your body recognizes the difference between its own self and something foreign that's coming in. And this whole ability is called immunologic tolerance. So your body's usually pretty good about saying, you're good, you're not so good. And then autoimmunity is when your innate mechanisms, which your innate mechanisms are like physical barriers. So like your skin, the cilia, mucous membrane, and then things like cells that like macrophages and things like that, that kind of target sort of non-specific pathogens. So when your innate immune system that normally prevents the immune system from attacking self-antigens fail, it then kind of activates your acquired immunity or your adaptive immunity, which is the one that sort of learns about pathogens. Like, you know, you get a cold and then the next time you don't get the cold so bad because you've learned that your body has learned about it. So when you have an autoimmune disease, that first innate immune system sort of messes up a little bit, which triggers the acquired or the adaptive. So conditions associated with autoimmunity is called an autoimmune disease. Oh gosh, I'm gonna have to move that. My notes are long and in the way in this picture. So there's two primary factors needed to develop an autoimmune disease. Oftentimes genetic predisposition could be a part. It increases susceptibility and contributing to the failure of that self-tolerance. So that could be one. An environmental trigger could be the other. And that could be triggered by a severe infection or like a bad fever or some kind of a severe traumatic experience. And then autoimmune diseases are often preceded by an infection. But I have some notes here, so I'll make sure I don't miss any of my. So an infection triggers a local immune response, causing the release of cytokines. We know that we get a lot of that activity with patients with periodontal disease. And then chemical stimulators that activate the self-reactive T cells. So it's kind of a cascading event. You get sick, your body starts producing stuff, and it kind of gets you into this hyper kind of mechanism of the immune system, producing an immune attack against self-antigens. So it's interesting because they can see a seasonal pattern. So there's a seasonal pattern of infections that correlate with the onset of autoimmune diseases, such as the systemic lupus erythematous that's observed with Epstein-Barr. So Epstein-Barr virus can be a seasonal thing, and then they can see this flare-up of lupus that goes along with it. And similarly, the Coxsackie virus in late summer can demonstrate like a seasonal flare-up of diabetes 1, type 1 diabetes. So it's kind of interesting how some of these viruses can correlate with how much of whatever of these autoimmune conditions that they see. So there's also emerging evidence that environmental factors contribute to autoimmunity, including low levels of vitamin D, exposure to UV radiation, and fluctuations in melatonin. So they're learning more about it all the time. There seems to be just more autoimmune diseases than there used to be. So environmental stuff probably is impacting it. So the common characteristics, it's cluster disorders presenting with more than one autoimmune disease. So there might be more organs sort of expressing some kind of a sign or symptom, and then multi-system organ involvement. So again, more than one part of the body is being affected. General signs and symptoms, a lot of times there's a lot of joint things that are dealing with the joints, a lot of fatigue, muscle aches, sleep disorders, anemia, which can have some oral implications that we might not always think about. So we'll get to that in a little bit. Psychiatric difficulties. A lot of times people with like fibromyalgia, there can be correlation of depression. So there can be some other psychiatric things, depression, frustration. It can be difficult to find a diagnosis. It can be really, people can live with something. They're like telling their doctors something's going on, and their doctors don't know how to diagnose them if they're not really attuned to it. I've known a lot of people who have finally gotten definitive diagnosis once they went to like a naturopath or a doctor that specializes in it, and they just, they were trying to get it figured out through their general physician or something. But with more than 100 different types of autoimmune diseases, it's, can be kind of challenging to get to that end stage diagnosis. So for medication use, there's kind of two big categories here: the anti-inflammatory agents, which we're pretty familiar with these for the most part, and then the disease-modifying anti-rheumatic drugs. So the DMARDs, they just kind of lump all these together. And then within those, we have things that we might recognize, like these immune modulators, methotrexate. You guys have probably seen patients that are on that. That's one that I've seen throughout my career. And then of course the hydrochloroquine, and then the immunosuppressants, cyclosporin, and this penicillamine gold compound. I can't say that I ever really remember having patients. So some of these are probably more common than others. However, it's just a good place to take a thorough medical history and then write down notes about what your patient is taking and any side effects that it might have on the mouth or their systemic system. So management of autoimmune diseases typically includes pharmacotherapy, beginning with anti-inflammatory medication. So that's oftentimes the first line of defense, and then it can progress to immunosuppressive drugs. So usually they start on the low and maybe a little bit of prednisone or prednisolone to try and tamp down your immune system response, and then they might amp it up from there depending on how it's going and how the patient is responding. So the goals of medication therapy used to treat autoimmune diseases include to reduce pain, improve the patient's function, slow the rate or progression of the disease, and then limit tissue destruction too. So if the inflammation, we already know that inflammatory response is what's causing, bone loss and everything. So we know that chronic inflamed state is not good for our body. So they want to try and slow that down to reduce tissue destruction. So NSAIDs, the non-steroidal anti-inflammatory drugs, they block the synthesis of prostaglandins. This is actually probably, you're not going to be tested on that. So you can just read that note to yourself. These are all in the notes. But what I do want you to know It reduces swelling and fever and pain, which you guys know NSAIDs do that. But the DMARDs, they prevent the prevention of joint and tissue damage often necessitates the addition of these disease-modifying anti-rheumatic drugs. So oftentimes they have to kind of, especially if it's a more aggressive or active autoimmune disease, they have to add some things to kind of keep from the patient from their joints deteriorating or whatever it is, if it's rheumatoid arthritis or whatever the autoimmune condition is. So you just have to take it case by case. So you notice back here with the corticosteroids like the prednisone or prednisolone, and there's another one, starts with a D. I'll have to look it up and put it on this slide, but they've been using it a lot lately in COVID patients, but it's a corticosteroid. But anyway, so with chronic use, so if you're, somebody has to be on prednisone for a couple of weeks or something like that, it's not such a big deal. But if you have an autoimmune condition where you have to be on a corticosteroid for like ever, it could potentially kind of be a problem. So patients undergoing chronic corticosteroid therapy are at risk for, we know, candidiasis. The most common oral side effect of these medications is candidiasis, which is related directly to xerostomach effects is a big part of that. And then they also may exhibit poor wound healing. So we know that, when we're trying to treat if they have periodontal disease or something like that, they're not going to respond necessarily as well. Oral infections may be masked. So if they're on immune suppressants and all this kind of stuff to dampen it down, their tissue might kind of appear healthier than it really is. So you have to put all your assessments together to really kind of discover what's going on. So just looking at a patient's tissue, you might be like, oh, their tissue looks pink and firm. And so then your probings, you might not be investigating your probings as thoroughly, because you're kind of reading their tissue and thinking, oh, it looks pretty good. And so sometimes with fibrotic tissue, we can probe too shallow. So you have to just be aware of that. And then chronic dry mouth increases, of course, the risk of caries and oral complications that would require our intervention. So we're pretty well versed on that. But here are some other chronic or some other complications of chronic corticosteroid: insomnia, so sleep issues, peptic ulcerations, osteoporosis, cataract formation, glaucoma, so things with the eyes, growth suppression, so this would probably be with younger kids, delayed wound healing, psychosis, weight gain, adrenal insufficiency, which can be a problem, we'll talk about that, and adrenal crisis, which is also be a big problem. Yeah.
Is it Cushing syndrome?
It's linked. Cushing syndrome is a lot of times when they have, it's like they're producing too much cortisol. It's like they have a ton of it. And so I think that their adrenal gland, they usually have like a tumor. But yes, Cushing syndrome is definitely in that place where it's working on the same, because your adrenal gland, which is affected by the corticosteroid medications. It could be that people who have Cushing's disease sometimes could have surgery on there to get the tumor removed, if that's what it is. I know we talked about that more last semester too, and it was in the PowerPoint here, but I feel like it wasn't quite as pertinent because people with autoimmune disease oftentimes they're taking steroid that can affect it slightly different than having a tumor that overproduces cortisol, which is the stress hormone. It's kind of complex. Yes. Yes, I knew it was a DEX. I'm like, it's Dex or something. Dexamethasone. Thank you. You get it all the time? Oh. Interesting. Okay. So oral side effects of medications. So dental hygienists must be aware that the drugs used to treat autoimmune diseases produce numerous adverse effects, and patients may present with signs and symptoms that select their drug treatment. So basically, we just have to kind of see what they're taking and then learn about it, because it's probably going to be a little bit different for everybody. Each patient requires a comprehensive history review, medication history review to determine the impact. So we know that pretty good at this point. So salicylates, which is aspirin, NSAIDs, and COX-2 inhibitors, they can affect bleeding. So we have to think about our patients with an autoimmune condition, and if they bleed easily, more easily, if there's petechiae in different areas that you wouldn't necessarily expect it. So things like that we kind of have to be aware of with bleeding disorders. They might bruise easier, gastrointestinal hemorrhaging, gingival bleeding. And then lesions may occur on the oral mucosa, including sort of appearance of a kind of blacker bruise. So they might have funny intraoral bruising that you wouldn't expect to see. And then immunosuppressive drugs may cause gingival enlargement and opportunistic infections and delayed wound healing and things like that. So we know that we can see some effects in the mouth for some of these. So when we're just planning our care, it's going to depend on their autoimmune disease, depend on their diagnosis, depend on the severity. We want to always consider powwowing with the doctor to see if there's anything that we need to know. It kind of is like a short morning appointments is sort of like the thing. Your cortisol levels are highest in the morning, so patients are most sort of able to kind of handle stress and things like that early in the morning. People tend to have more energy, be a little bit more awake. So it just kind of, it applies to so many conditions. We always say short early morning appointments. It's kind of just the go-to. The same with diabetic patients, that just kind of their blood sugars are more stable in the morning, and it just kind of is for lots of different conditions. But oopsies, okay. Hold on. So yeah, physician consultation. We want to think about if there's any unusual oral complaints or manifestations. Ask the patient, how's that medication treating you? Have you noticed any different oral manifestations or anything that's bothering you? They might not know the word oral manifestation. They might not know what you mean, but anything in your mouth that's new or different or bothering you, sores, lumps, you can just name a few things that you might think they could be experiencing. And then, just like we already talked about, we want to consider how long they've been on the corticosteroids, if they're taking any blood thinners, if they need pre-medication. It's not as likely that somebody that has an autoimmune disease will need pre-medication, but if somebody is on heavy immunosuppressants, it possibly could mean that they need antibiotics. So it's there in a lot of slides, the pre-med, like question, do they need pre-med? But really it's more because what's their specific? Like most people probably wouldn't need pre-med, but it's just to always have that trigger in your brain. Like, is this person, severe enough that this is a problem? And then immunosuppressant drugs. Okay, so we'll go over a few maybe more chronic autoimmune diseases and some oral manifestations or things that we have to think about. So this is kind of a list of it. So adrenal insufficiency or Addison's disease. So I wrote some stuff on this. This is the slide that I kind of changed. I took off the cushions because that just didn't seem to fall in line quite so much, because it's a lot of times it's from a tumor in the pituitary gland. So, and it wasn't in the textbook. So I think I had added it there. I don't quite know why, but anyways, I took it off. Chronic use of corticosteroids. Basically, they suppress the body's own production and release of cortisol. So if somebody's on a corticosteroid, that our natural production of the stress hormone, it kind of suppresses it. So the fear is that when somebody needs their like surgery or a stressful situation, they won't have it, that it will have suppressed that production for so long that when they need it, they won't have it, and they'll go into an adrenal crisis, which can be deadly. I mean, very dangerous. So let's see, let me read my notes so I'm not missing anything here. And that can happen resulting from medication-induced adrenal insufficiency is probably one of the major things that we'd be talking about. The danger is when a patient needs it, I already said that, they won't have it. The patient will not be able to produce an adequate amount of his own cortisol, known as the stress response, placing him at increased risk for cardiac output, so it affects the heart, hypoglycemia, that's no fun, and circulatory shock. So bad things can happen if a patient's body doesn't respond, and surgery puts patients under a lot of stress, and that's a time when cortisol is really necessary. So if they don't have that, it can be a big problem. Adrenal crisis is a rare life-threatening condition caused by acute adrenal suppression. So the adrenal gland has been suppressed. Addison's disease is when the adrenal gland has been destroyed either by infection, cancer, or chronic steroid use. And so that's just a concern of patients who are under heavy steroids for their disease or condition. So does anybody who wants to pronounce this word for me? Is it, I know it's pemphigoid, but I have the hardest time with this word. I knew you guys would from oral pathology. Cicatricial? Cicatricial? I'm going to put it after I should have done. Yes, I'm going to ask Kathy. And the other thing I should have done, sometimes I Google it and then they'll have a little voice thingy and then a robot will say it. Who's on it? Someone's going to tell me. Cicatricial. Thank you. Thank you, robot woman. Cicatricial. So cicatricial pemphigoid. I'll never forget it. What did it say? Oh, that sounds much prettier because it rolled the R. Cicatricial. I tried to roll my R. That was bad. All right. So this is a benign chronic blistering disease affecting the oral mucosa. It can affect any area where you have mucosa, basically, but it's a benign blistering. So in the oral manifestations, we'll see vesicles or bulle. I need to talk to Kathy before I do this. Bulle that ruptures, leaving areas that are ulcerated or denuded. And of course, you can imagine that would be painful, right? And they can go on for weeks or months if untreated. So for our intervention, there's topical pain control, treat lesions with topical or systemic corticosteroids. So it probably depends on the person again. If this just kind of comes cyclically and it's not that bad, maybe they just deal with it. Maybe they have to go on some kind of a steroid to kind of suppress it. And it probably depends on where in the body and what mucosa, if it's in the eyes or something, that would be a really big deal. I'm sure all of it could potentially be a big deal, but for us, we probably aren't likely to see it as often. And then we would just find out what they're being treated with. And if they keep saying, I get this and I don't know what it is, then you might, it might trigger in your memory, oh, maybe this is that pemphigoid thing. And then you can help them by talking to their physician about that, and they could get it biopsied. Fibromyalgia. So oral manifestations of fibromyalgia, patients might experience TMJ dysfunction and pain in the face, head and neck region, and xerostomia. So just kind of some achiness there. And then for our interventions, we can refer to the physician if they're explaining this to us. We can kind of help kind of triage with a physician. If they're experiencing xerostomia, like with any patient, they're obviously at higher risk for caries, and they need all of our tools that we have in our backpacks for that, fluoride, xylitol, remineralization. Salivary replacement therapies, if it's really bad, they do have medications that can help with the saliva. And then of course, just the rinses and the gels and things like that. And then consult for TMJ pain and jaw pain if it's really a just a kind of a localized issue where that's where they're having a lot of their pain. But usually people with fibromyalgia have a lot of kind of all over pain and fatigue. So a widespread musculoskeletal disorder characterized by pain in the muscles, ligaments, and joints, and overall kind of fatigue as a frequent comorbidity with other autoimmune conditions, including chronic fatigue syndrome, rheumatoid arthritis, lupus, and hypothyroidism. So sometimes it comes in with other autoimmune conditions. Hypothyroidism, this one has some interesting pertinent things. Oral manifestations, I don't remember, this is kind of interesting. I don't remember talking about that at all, but some mild tremoring in the tongue, osteoporosis. So that could be something that a physician might see. We wouldn't obviously see that unless it was having to do with resorption of the jaw or something, faster bone loss, or we might note that in our chart notes, or if we, over the course of taking radiographs, we might notice it. Children, premature loss of deciduous teeth, accelerated tooth eruption, and faster development of the jaw. Adults, marked loss of alveolar process, so some changes in their structures of their bone. Diffuse demineralization of the mandible, so that would be a radiographic evidence. Rapid progression of periodontal disease. And then here, the lingual thyroid appears on the posterior dorsal region of the tongue, below the area of the foramen cecum. I'm not so sure. I mean, I'm not so sure how we would see that very easily unless we were really looking down their throat. Dental hygiene intervention. So this is interesting because we palpate the thyroid, you know, but it talks about not over palpating the thyroid, especially with someone with hypothyroidism. So that's important to know. They're going to be more sensitive to pain, so they might need more anesthesia, but they're more sensitive to the catecholamine, so then we might want to limit vasoconstrictors, the epinephrine. So we just want to be very cautious of that. And you guys probably remember that from your pain management class. More tolerant to the centrally acting drugs, so they might need a higher dose of anything that works on the CNS, the central nervous system. And then, like with many things, we want to manage stress and anxiety and monitor their vitals. That minimizing risk of the thyroid storm is one of the biggest things. So make sure I'm not missing anything here. There's just some kind of background notes on the thyroid there that you can read through. Multiple sclerosis. So oral manifestations occur in 2 to 3% of this population. So it's not a huge, there's not a ton of oral manifestations, but paresthesia, difficulty with speech, oral facial numbness, trigeminal nerve, and drug-induced xerostomia. So if somebody has an MS flare-up, maybe they would notice some of these things going on in their, some numbness or some difficulty with speech. Pain too, affecting the trigeminal nerve. And then our interventions with MS, patients with MS is of course that shorter morning appointment, just so that they can kind of handle the stress of that. And it's a little easier for them. Treating during remission. So if they are having an MS flare up, they probably won't be in your chair, which is good news. Avoid treatment during active disease period. Steroid supplementation may be needed. They might be taking these prescriptions like steroids. Provide assistance with ambulation. So they might have difficulty getting in and out of the dental chair. So that's something to be aware of. We have to think of all the same therapies for patients with xerostomia, which is pretty much the same. And augmenting our OHI in case they have dexterity issues as well. So MS is the most common autoimmune disease affecting the nervous system. And we learned about what it actually is with the demyelinization of the nerves in the central nervous system because of chronic inflammation. So, and that's actually pretty common in the Northwest. And we talked about that quite a bit in our old lectures ago. So myasthenia gravis, this is kind of an interesting one. I had 2 patients in a really short span of time, a male and a female, that had myasthenia gravis, and they presented very different. he presented very classic, like the tone of his voice was different. And he said, like, I didn't used to talk like this. And he had a lot of weakness in his throat. He could not handle the ultrasonic. He just, it was affecting him harder. And he was taking quite a large dose of prednisone, I think. So, but oral manifestations, drooping eyelids, double vision, and that was the first thing that he noticed. That's why he knew something was going on, is he had double vision. And I think that happened with the female patient that I had as well. Muscle weakness in the face, head and neck, difficulty chewing, swallowing, difficulty wearing dentures, soft palate is weak. Everything has a very weak feeling in the like throat area, impaired lip movement, altered voice with a nasal tone. He totally had that. And he kept talking about how weird everything was because he didn't used to talk or sound that way. So interventions assist the patient with the feel of oral hygiene aids. If they're having visual problems and they can't really see what they're doing, they might not feel as well what they're doing. They might have like just less sensation overall. So you kind of have to either, if they can't see what they're doing, then you kind of rely a little bit more on that feeling. But if they have lost some of that sensitivity in their oral cavity, then you just have to kind of work with them, each one. But use hands to support the lower jaw during mastication. He literally told me that he had to support his jaw and like help himself chew, because he wasn't coming together. He just wasn't coming together to grind his food. So he was like very classic with a lot of these things. Possible spontaneous jaw dropping, like the jaw just drops. Implant supported dentures. So if the dentures just aren't working, then a lot of times they'll recommend implants to actually hold the denture in there. Short early morning appointments. They can't handle the fluid as well. So rubber dams or mouth props, they can't keep their mouth open as long either. So all of these things kind of help for the safety of the patient and so that they don't choke on the fluids. Consider nitrous oxide to reduce stress and anxiety. Caution some antibiotics have muscle relaxants property. This wouldn't be so much we wouldn't be probably prescribing, but dentists need to be aware of that if they don't realize that that's a thing. So that's important for us to kind of know so we can help support the dentist and if they happen to be prescribing antibiotics, and then monitor their ease of breathing. So myasthenia gravis is a chronic autoimmune disease that affects the neuromuscular systems, representing a decrease in acetylcholine receptors in muscle fibers, resulting in progressive kind of just not as good of communication between those synapses. And so therefore you get a lot of that skeletal muscle abnormalities. Some autoantibodies inhibit receptor function on the cell, as in, this was a note from in the beginning of the chapter. It was talking about how some autoantibodies inhibit the receptor function, which is what's happening with myasthenia gravis. It's a receptor issue with the acetylcholine receptors inhibiting their neuromuscular transmission. So basically it says the same thing just twice in the notes, just kind of worded differently. Pemphigus vulgaris is another one. And where are we with time? Oh my goodness, 2 minutes. Okay, I'm just these are just oral manifestations and interventions. Sorry, I just have to see if there's anything super important that I want to say before I let you guys go. Yeah, I can finish it. I can actually go finish it in my office and then I'll post it. So this is all just going over these last ones. And then I just want to see what so the process of care is what we always do. We just take each patient by an individual basis, considering their medications and the severity of their disease. This is a scale that you can use. I have difficulty opening my mouth. I have to avoid certain drinks. I have difficulty chewing. So if your patient is having some kind of symptoms and they don't know, they haven't been diagnosed with anything, you can use this for them to kind of help articulate what's going on and what their limitations are. And you can always send that to a physician and say, and so you can say, my patient is experiencing these things. And then hold on. And then final thoughts, minimizing infection, restoring health. With our education, we always want them to keep their mouth healthy, especially since they're more prone. And then some of this stuff is just sort of bullet points that you guys will already know that I will. And then this is just an overview of all the products that we use, because so many of our patients are going to need, you know, they're going to have higher risk for caries and whatnot. So saliva substitutes, fluorides. So it's kind of repetitive because a lot of them will show those same needs. So I'll finish up that and then I'll post the recordings. All right, just let me know if you guys have questions about questions or fears about the exam, and I'll try and answer them the best I can before next week.